is Kizito Ogusan. I will be one of your speakers today, and I'm in charge of the housekeeping. So you will notice that you have now entered the platform with your camera off and audio muted. And please keep your audio muted at all the time to avoid background noise at the minimum. If you are invited to speak, please unmute yourself to present the, by clicking on the microphone button and the bottom left hand corner, and feel free to switch to your video again by using the button.
Automatically, you become part of it, but
by using the button in the left. So now
yes.
We have.
Yes, I think you're talking, but I'm not part. I'm not today in the meeting.
Okay, good. So if you wish to interact during the session, you have now the choice to use the chat facility on the virtual meeting platform and
yes,
on the Zoom. Russell, can you help us meet the speaker? You will find this by going on the agenda tab in the virtual platform and clicking on your section, which you should have already accessed to reach this workshop. Hopefully you will all have seen the email sent on Monday and detailing how to communicate during workshop with the chat facility if you are operating on the screen. So you can view both the chat and the presentation. Please email MIT if you are having difficulty in using the chat facility. And thank you very much. So on that note, I will give the floor back to the moderator, Bruno.
Just to note as well, these sessions will be recorded, so please email us if you have any issues with this being recorded. Thank you.
Yeah, thank you, Kizito. And good morning, good afternoon, good evening, depending where you are in the world. My name is Bruno Boucher. I'm the director of the Health System Strengthening Division here at FHI 360, based in Washington, D.C., working from home like probably anybody else. And very warm welcome to this session on the application of quality improvement to strengthen the performance and improve the quality of NTD programs. I'm going to be your moderator today for this 90-minute session. And the agenda is the following. We'll introduce the topics, obviously, and the rationale for selecting this topic. We will have then 3 presentations, and I will introduce the different speakers, who will then gather as a panel for a 30-minute Q&A session with a debate that we have framed around specific questions. And I want to introduce now a little bit the topic and the session itself, the content of the session. There are basically two issues that we selected in order to apply for the application of quality improvement that we're going to debate today and present. One has to do with the low coverage of preventive chemotherapy for the population selected at sub-district level, which, as you know, if the coverage is low, is leading to a failure of the DSA, the different surveys that confirm the stop of the transmission of the diseases. And the second one has to do with the quality or the poor quality of the data and the disease-specific assessment, which leads to obviously unreliable results, and especially with trachoma impact assessment surveys, but not only. And so the question that the issue we wanted to address these issues, basically we decided to try using a model for improvement that has been used in the field of improving quality of healthcare services. But that's designed not just to address quality of services, but to address the performance of a system in general, which we have applied extensively to the health system. But that's a model that will be described during this session, but has not been applied to NTD programs. So we are, in a way, trying something new. Next, please. And so the issue we dealt with is how to integrate this improvement model, how to customize it, how to apply it to a program that functions by campaigns, through MDA campaigns, which all of you are very familiar with, and using each MDA as an opportunity, MDA campaign as an opportunity to try something new and to learn from it, which is the basic conceptual framework of the quality improvement model. And that requires to target the steps of the MDA campaign from preparation to evaluation with changes, because there is no improvement in the performance of a system without changes made into this system. Next one, please. And so we design the improvement process as a test itself by testing changes on a subset of districts during an MDA campaign, that's the intervention group, and comparing the result with the control group where the MDA is conducted as it was before, or with any type of improvement that came from the lessons learned. So each time that there is an MDM campaign, it is an opportunity to try something new by testing changes on a subset of the populations that are targeted and the districts that are targeted by the MDA. Next one, please. So this is the basic conceptual framework that helped us design the application of quality improvement to NTD programs, and that is going to be the focus of this session here. There are going to be three presentations. One is going to be done by Dr. Kisito Ogusan on the quality improvement model itself, for those of you who are not familiar with it. The second one is going to be done by Dr. Ibrahim Kargbo-Leber for the planning stage of the test of changes and the improvement itself in Sierra Leone. So it has not been completed yet, but it is at the planning stage. And then from Dr. Benjamin Marfo in Ghana, we're going to learn about the result that they have achieved with the application of the quality improvement model. Next one, please. So after the three presentations, we're going to have a debate and we identify some issues that we address, but are not for which we need to continue learning from. And one is how to integrate QI into a program that operates through campaigns, whereas the traditional application of the quality improvement program is on healthcare services that are delivered on a continuous basis, whereas a campaign in a specific event. The second is how do we measure the effect of changes for NTD programs and conclude that the changes that we made, that we tested, are effective or not and should be integrated now in the next MDA campaign and in the program in general, including for improving the quality of the data. And then the third one is how do we test the validity, measure the added value of QI for NTD using a mix of implementation science and formative research. There are a lot of data, including qualitative data, that we can learn from the test of the changes that are being done. So I'm going to now introduce our first speaker, who is Dr. Kisito Ogusan. Dr. Ogusan is currently the FHI 360 Implementation Management Lead on the USAID-funded Act to End NTD West programs with FHI 360. He has more than 23 years of experience in public health and global health implementation and research, including 13 years managing neglected tropical disease programs. He's a trained medical doctor with a Master of Public Health degree from the University of South Carolina. Dr. Ogusan, you have the floor.
Thank you. Thank you very much. So Bruno, can you still see my my screen? Is my screen is okay? The slides.
I can see the screen. It is split into two different parts. I don't know if it's the same for anybody
Okay.
else. But,
I should.
it's not for the slides are not full screen.
Yeah, the slides aren't full screen, Casito. If you can go up to the display settings,
okay,
and then press switch to presenter view, swap presenter view and slideshow. That first button.
Oh, okay. Oh, great.
There you go. Now we can see it full screen.
Okay, thank you.
No worries.
So, I'm going to talk about quality improvement, the model itself, and how we apply to NTD program. What are the opportunity we use to assess that this model can be applied to, as Bruno put it, a campaign like public health program. So this is just a disclaimer. So the fundamentals for quality improvement model is based on the fact that there is no improvement of performance without thinking of the system. So, and making changes within that system. You know that the system will produce the outcome that the system is designed for. And so if you haven't made a change, so you still have, you will have in all time the same output and outcome. So that model is should be applied usually to a complex system with, of course, many components. And all we know as a public health practitioner, we know that we need to put our complex system in place, encompasses inputs and processes to obtain our target result. So all those processes interact in a specific environment and produce the result that we aiming for. So we need a model for improvement that promotes evidently that system thinking and is designed to test the changes, usually on a smaller scale. You could call it piloting, and learn from it before using as best practices. So FHI 360 has used this model and based on the collaborative model and the model of improvement for improvement. So the model has three main questions. What are we trying to accomplish? So you need to making sure that you have your aim and objective clear enough to move forward through to use this model. And you need to making sure to answer to the second question, which is how will we know that a change has led to an improvement. So you have to develop sort of a monitoring system, a measurable system that will give you that will give you your precise target. And then you have to ask yourself that if the changes you have tried is the one really leading to the result of improvement. But of course, it's because you have put in the system a change of idea that you try to look at the effect of the change of idea into your system, that the result you have will be the output of your system. And if the result is what you are looking for, you are aiming for, then your idea of change is the best one, is the one that have led to the improvement. And so, as I say, FHI 360 prefer to use these framework, plan and do. So you making sure that with regard to your M and with regard to the monitoring system you put in place, and your objectives that are measurable, and that the result you have is the target you're looking for through your M. And when you apply it on the small scale, you evaluate the result, and then if the result is what it is, what you're looking for, the improvement you're looking for, then you can scale it up and sustain and spread to the system, to the whole, I would say, to the whole program. So what are the phases of the quality improvement implementation process? First of all, you have to design the improvement effort. Usually, you start it by doing a rapid assessment or situation analysis, and that will help you to making sure that the problem or the challenges you address it are recurrent and real. And you develop a roadmap for that, and there is steps that you have to take to do so. And of course, you put in place a structure to implement the roadmap that you've put forward, and you establish a monitoring system to measure your result. You test it at the small scale, and if you have identified changes that are related to your objective and your aim, and that you have assessed the result, meaning the effect of the changes you put together, and making sure that all the processes and the system are followed properly through, by putting a coaching system in place, and the coaching system help you to monitor your implementation of changes. As I said, when the result you obtain is the one you're looking for, you can use that practice, that change of idea as best practice, and scale it up to new sites. So usually there is a set of tools, a lot of tools that borrow for quality improvement model environment words. One of the tool is the root cause analysis of performance that help you to categorize, especially in health system, that help you to categorize the issue, and depending on the effect you're looking for, saying 25% of tuberculosis patients in the DCS did not complete the treatment and direct observed treatment for the past 3 months. You categorize your issue by usually in health system, we have the facility supply, the leadership, the community leadership, the financing, the human resources you need to manage your health facility, the information system you are using, of course, the community you are rendering the service to. So if you categorize to those big issue, and then you look at the detailed issue and categorize them to relate them to each of the big category you have selected, by asking yourself, why is it, why do I have this problem? And then if this problem is related to facility, then you make an arrow of the problem to the facility. And you ask yourself the why until you get to the detail that is satisfactory to you with the issue. There is another called diagram, driver diagram. It helps you to visualize the relationship about the driver of your M's. And usually the main driver are either a couple of or 5 drivers. It's better to keep to 2, but you could go up to 5. And there is other secondary driver that contribute to achieve the M of your project. So you use that, especially the contributor to determine what will be your change of idea that you will use to plan. But the most important I want to talk about is the plan, do, study, and act cycle. This cycle is designed primarily for regular health system, but we adapted to use it for NTD, and neglected tropical diseases program. So you plan by determine, of course, is more or less your chart. You determine the M and state your specific objective. Of course, you plan your implementation of your change of idea by doing the regular program management, who, what, where, do, and when and how to do it. And then you carried it out and you studied by tracking the results through the monitoring system you put together. Of course, your objective should be highly measurable, and you summarize your finding, and upon your finding, if depending on the result you have, you can decide to use it to apply to the next cycle. So usually in a regular health system, there is you have to use regular a different cycle, because each cycle allows you to test an idea, to study, to see if where the result are satisfactory. You use them to apply to another cycle, or you change your idea and you restart the cycle again with the new idea. By you know, average 3-4 cycle, usually you get what your change, your best practices that you can scale up. So just to touch upon quickly rapid situation analysis that allow you to define and to define the border of your system, and to assess the process, and making sure that you know the environment in which you will be working, know all the stakeholders. The quality improvement charter, as I say, is the roadmap, is the document that describe your improvement effort, and is structured according to the QI models, to provide you visibility onto what you wanna put in place and improve, of course. People you need a structure to manage. People you need to manage are categorized in 4. The QI team itself, which deliver the services, which implement the charter, the roadmap, and of course analyze the system. They collect the data for analysis, test the changes of idea, measure it, and report on the result. You need a team of experts. In this case, NTD. Those are authority that in charge of the program, that put the policy together, review and make a recommendation upon the result the program is generating. All of that are based, of course, on scientific evidence. Those are trained people, and of course, they know well how to communicate within their domain. You need the leadership management team as well to have buy-in of the QI because it's done in a small scale, and of course you need to have the leadership buy-in to do so. They also review the result. They are the one to approve actions. And of course, the most important here in this case is the expertise on QI. Those are people who knows the model, who knows the tool, who can tell you it's better to use in that case the diagram, the driver diagram instead of fishbone. It's better to use the Pareto here for what you're looking for. And they coach the team and help them to collect information and lesson learned. So why can we apply to NTD? It's because it's a complex system. Never mind the slide you have seen. It's just to show you how complex is planning an MDA in NTD. But since the QI will be applied to a complex system, and you have to think in system, then and this is well in the remit of program to which you will apply the QI model. Of course, we go all through all those stages where we plan, we execute, and we evaluate, and we decide onto the result we have. So what are the challenges that we've noticed in fiscal year 2019 and fiscal year 2020? We've noticed that we have an issue with low coverages, especially we've had to reach population, of course, conflict area, in the border area where we have population movement, and especially in area where there is a lot of nomadic population, transient population that goes through border from Sierra Leone to Ghana and so forth. So we've noticed those issues in, as I say, in Ghana and Sierra Leone to cite those. There's other countries I wouldn't cite them because they're not part of the workshop today. And we've noticed that we have also an issue related to impact assessment, or what we call it disease-specific assessment with regard to lymphatic filariasis pre-transmission assessment survey. We've noticed that Sierra Leone and Ghana have experienced Pre-TAS failure. And in some cases, there is a transmission assessment survey 1 failure in West African region. Also, with regard to trachoma, the impact assessment, the trachoma impact survey, and trachoma with regard to the trachoma impact assessment, we've noticed that some country has failed as well. So those issues are systematic issue, recurrent issue that we could address with QI. The QI, we definitely see that there is an opportunity for the quality improvement to be applied to neglected tropical disease program. So we suggest to some colleague in country to use this program to address the recurrent challenges. Bruno, I hope I haven't gone over the time.
Yes, you did, Kizito.
Just a little bit. It happens.
4 minutes.
Okay, so thank you very much, Dr. Ougousan, for this overview of what we call the model for what is known as the model for improvement, and the introducing the concept or the idea that maybe this model can be useful or can be used to improve the performance of an NTD program with a focus on MDA and the quality of the data from the different surveys that are part of the NTD program. I'm going to now pass the floor to Dr. Carbo-Leber, James Carbo-Leber, who is going to tell us how they are planning to use this model to strengthen the performance of the NTD program in Sierra Leone. Dr. Carbo-Leber is a medical doctor and a public health specialist. He has worked extensively in his home country, Sierra Leone, both as medical superintendent and district medical officer, coordinating all health activities in the districts. In his current role, he is the program manager for National Neglected Tropical Disease Program in the Ministry of Health and Sanitation. He obtained his medical degree from the Cuban Medical Academy in Russia and has a Master of Public Health from the University of Ghana School of Public Health. Dr. Carbo-Leber, you have the floor.
Good morning, good afternoon to everyone. I'm going to present planning for quality improvement initiation in Sierra Leone, how to design your test of change. I'm Dr. Ibrahim Carbo-Leber. I'm the Program Manager, Ministry of Health and Sanitation. Next slide. Next slide. Well, the background. Two districts in the north, 4 districts in 2013 failed the Pre-TAS. 4 of them that are bordering with Guinea failed Pre-TAS in 2013. And in 2017, this time, 5 districts failed the Pre-TAS, that is including Western area rural. The 4 districts that failed the Pre-TAS in 2013, and then an additional Western area rural. So 13 failed in 4 failed in 2013 and 5 in 2017. In spite of the fact that they have more than 65% epidemiological coverage. Next slide. Issue we want to address. Of course, the issue we want to address is the 4 districts that failed Pre-TAS in 2013 and an additional 1 that failed in 2017 using the FTS. We want to address that issue. How do we know it is a problem? Of course, it's a problem. Failing twice, 2013 and 2017, it's a problem. And our goal is to pass Pre-TAS in these 4 hotspots. The objective, of course, is to improve quality in MDA coverage, Pre-TAS and TAS2, supply chain management. We want to improve coverage in all these areas. Next slide. Quality improvements. We want to pay attention on 4 themes themes, that require attention. And these are the data quality, community engagement, supply chain management, and the Pre-TAS. Those are the 4 themes that we want to concentrate on. Next slide. Now, there is an issue with this sub-district data. If you look at the diagram, Kailaon districts, 1 peripheral health unit have a MDA coverage below 65%, and 3 peripheral health units have a MDA coverage of above 100%. Bombali districts, 3 PHUs have below 65%, and 2 have above 100%. Kwenadugu, 13 have below 65% MDA coverage, and 20 have above 100%. And Kenema, 17 below 65 and 2400. These are the 4 districts that I failed Pre-TAS twice. What are the causes? Number 1, CDD census inaccuracy. It's a big problem. Most of them don't know how to fill the forms properly. Number 2, increased urbanization in these areas. Increased migration for employment, for schooling, trading, you name it. But the migration has increased tremendously in those areas. And number 4, some of these places, right, they don't access MDA in their locality. They access it in another locality. For example, we have what we call market days. If you go to some of these villages, even their dogs are not there. They have all gone to these big towns on market day. So we catch them on market day, right? Then you will have a surplus over 100%. And then when you go to another place, it is below 65%. So this is the issues of sub-district data, and these are the causes. Next slide. Data quality, another problem. How do we want to enhance data quality? Number 1, we want to do regular updates of the CDD census register. Pay these CDDs, because when you pay them, they are more motivated to do the work than non-payments financial. They appreciate more when you give them at least $2 per day. That is our experience from the last data that we updated. And then you do training. You train all the DHMT members, the PHU members, the CDD on sub-district data management. You do repeated mopping. And then, of course, you upgrade the training manual regularly. And next slide. Oh, supply chain management. How do we improve this area? We have problem with pharmacists and storekeepers. Our pharmacist left us for greener pasture. The storekeeper was very, very ill. So thank God we have trained. We recruited and trained storekeeper and M&E officer, and we trained them on NTD drug management and inventory control. Those are the two people you are seeing there, the storekeeper and the pharmacist. And then we strengthen logistic management information system. And then the reverse logistic is also needs strengthening. Next slide. Quality implementation. How do we do quality implementation of Pre-TAS? Now, the first thing we'll do, we'll train the field supervisors and supervisors team on approved or updated survey tool protocol. After training them, of course, the people that we train them is NTDP staff, Ellen Keller staff, and FHI 360 LF technical advisor will do the training. And from the training, we do pre-survey community sensitization so that the community will be fully aware of what we are going to do in their community, or else we'll get problem. After the sensitization meeting, we'll do collection of samples with LF bench aid. And then from there, we'll do collection of data using the electronic data collection forms. Next slide. Oh, issues. Issues are plenty, but these are some of them that we are able to highlight. The main issue, even from sampling more than 20 people, 18 of them is this state of denial. They don't believe that, right? LF is caused by mosquito or is transmitted by mosquito. You don't then tell them, they just don't believe it. Said, well, if it is caused by mosquito, well, all of us will have Bigfoot because all of us have malaria. Why some are having Bigfoot and others are not having Bigfoot? You are living in the same place. So they argue. They don't believe that mosquito caused that thing. So it's a problem to convince them that it is mosquito and not wish or cockroaches or you name it. They have all those negative thinking. And another thing they don't, especially the young people, they have this hostile, they are very hostile. You have communities that are very hostile, especially if you are coming from the opposite community. It's not easy to allow to enter their community and tell them about LF. Call them hostile communities.
Dr. Ibrahim, you have 1 minute left.
Okay. Hostile communities, and then these, you have these people that don't trust, lack of trust. They don't trust the process. Next slide. Next slide. Oh, yes. Rapid assessment of social dynamics, adopting the approach using the Ebola vaccine trial strategy that focus group discussion, in-depth interviews, ethnographic observation, power mapping, and rumor tracking. Findings will help to start the process of identifying the change of ideas. Thank you. Am I there?
Yeah, thank you very much, Dr. Ibrahim, for telling us about a lot of the ideas that you have that you want to test. You're in the planning stage of testing these changes. These are ideas that can be tested again using the improvement model that Dr. Augustin described before. So we'll be learning from you next time when you present the result of these changes and the learning from them. I'm going to pass the floor now to Dr. Benjamin Marfo, who is going to describe the results. They have been in Ghana on a more advanced stage in a way of using the quality improvement model to strengthen the performance of the NTD program. And so we are very interested to learn about the results and the lessons learned from Ghana. Dr. Benjamin Marfo is a public health physician, specialist, extensive experience working on NTD programs, malaria, HIV, tuberculosis, and maternal and newborn health. He's currently the program manager for the national NTD program at the Ghana Health Service, overseeing control of onchocerciasis, LF, schistosomiasis, soil-transmitted elephantiasis, and trachoma. Dr. Marfo graduated as medical doctor from Vitebsk Medical Institute in Belarus. He received his master's in public health from the University of Ghana and has been a Herbert M. Frey Fellow in Public Health Policy and Management at Tulane University. Dr. Marfo, you have the floor.
Thank you very much. And I'm glad.
We cannot hear you, Dr. Marfo.
I am a participant of this very important meeting and also a speaker for this very important meeting. Duty here is quite simple. Dr. Kizito has already given us an update on the QI model. And then Dr. Ibrahim has also spoken about the planning to do with QI. So I will quickly take participants through the background, and then I'll zero in on the results and the lessons learned. Okay. Let's start. Good. So Ghana began the LF program in 2001. We now have 260 districts. So basically 114 were endemic for LF. And we're talking about a risk population of around 12 million. And then we've been able to break transmission of LF in 99 out of the 114 districts. In 2019, the treatable population in the 15 districts were just. We've had a high prevalence of LF in 15 districts, that we call the hotspots. These are districts that have received between 15 to 19 MDA runs. So the question is, we have a Pre-TAS failure in them, but why the persistent Pre-TAS failure? Which factors are responsible? Next. Yes, so okay, so like I mentioned earlier, we have 15 LF hotspots, and these are the prevalence that we had from 2014 to 2019. And I wouldn't belabor the issues at stake, but if you scan through, you notice that if with regards to the microfilarial test, we persistently, quite a number of the districts back in 2014 when we were doing the microfilarial tests, were always above the 1% threshold. When we started with the antigenemia test, the FTS also had quite a number being above the 2% threshold. Next. So we've had high non-compliance, and then we've had some studies that have been that we have come up with, which somehow underpin the fact that we had issues to do with serious high non-compliance, and then there had been incomplete and inaccurate data through this very study. Next. Good. So in order to really understand the causes of some of these identifiable causes which I have mentioned, we had to look at the poor data quality and to know what was associated with the poor data quality. That the non-use of standard examples are the non-use of standard reporting format, no validation or verification of data, then urban-rural population dynamics, the population, there's also the population movement and migration. Then the community issues were low participation due to the low level of awareness and inadequate engagement with stakeholders and leadership. We also had CDD issues, poor selection of the CDDs. Ideally, CDDs should be selected by the communities, but sometimes you have a section of the community doing the selection, or sometimes that is done by health workers, and that doesn't inure to the benefit of the work of the CDDs. And there was ineffective training, and then we noticed that there was non-observance of DOT, and there were issues to do with from the health services, growing leadership apathy, poor timing of NDA. Next. Yes, so what was the aim of this whole thing, of the QI? Wanted to improve MDA effectiveness in the LF hotspot districts. And then the objective was to increase MDA non-compliance and improve MDA data quality. So we had noticed that there was a serious level of non-compliance of the ingestion of the medicines, of the MDA. And that we thought we had to address. And we needed to also improve the MDA data quality. Again, we had issues to do with the population that will be. Next. Yes. By virtue of the QI model, we started the implementation of the QI from 2017, and then it ended in 2019. We are thinking of evaluating the QI project somewhere next year, 2021, and that will help us move to be able to scale up the rest of the country. So basically, we went through the first year with the learning sessions where we had to establish the program fundamentals, and that involved identifying the issues, the root causes, generating the action plans, and then we use, based on that, we had to move to the second stage, the learning session 2, where there was peer review, where we could take the change ideas or the strategies that the teams will use to address the challenges. Then we'll move to the learning session 3, which is about putting together all the challenges, then the best practices, so as to sustain the gains. So you can see from the maps that we started, the first map, that's the map of Ghana. We started as a pilot in one district called Brim North. Then from there, we moved into the 15 LF hospitals area. And then we are now like I mentioned earlier, we have to move into the evaluating the results, and then we'll scale up to the other parts of the country. That will be the third. Next. So the change ideas tested. We will have to review. There was review of data. There was this data management training model that was reviewed. Instituted data validation and verification. Then we had to look at the populations once again, trying to separate some of the migrant settlements from the main communities, and to make sure that we're able to know, to elicit the MDA in the migrant population, and also separate that one from the MDA in the main community, so that we know how to map out strategies to target these two groups of people. Change ideas still tested. We have to the health system factors, that's engagement of the stakeholders, including partners, to review the MDA treatment cycle. That has been a major issue where partners insist on reports at a particular time of the year. And sometimes it's not so conducive because that period also, before the reports are even, before that period around the MDA period, it could be a rainy season or the weather may not be too conducive for the MDA, but because there's pressure from partners, we need to respond to that. And so these are some of the things that we have to still work at. In the use of the new supervisory coverage tool, which we have now, it empower delegation to regions and district staff to own program. That they improve sensitization, effective engagement of social groups, and then the CDD related the review of our CDD training manual, and then enhanced CDD incentives. Next. Yes, so we'll go through this as yes. So that the process indicators where we look at the proportion of community meetings held in the sub-districts, the number of communities for which rapid assessment checklist was used, and then the outcome indicators. Now we look at the non-compliance rate, MDA coverage. Yes, next. Time is not so much on our side, so yes. So if you take one of the LF spots called as municipal, from 2014, you realize that the non-compliance rate was somewhere around almost 7.7, then moved down to the 5.7, 3. But when we started at QI, non-compliance rate has steadily reduced from 3.1 to 2.1, and that is to do with the outcome of the QI that we have implemented in this very district called Azim Municipal. Yes. Yes. So this is the crux of the matter. We looked at our data, whereby we realized that sometimes even the registered population was seriously advanced to some of the combined indicators of the treated population, non-eligible, refused, and absentee. Normally, usually the treated population, non-eligible, the refused, and absentee should commensurate with the registered population. But we're having major gaps before the QI, salient major gaps. But as and you can see from here, in 2013, in Tsunami Municipal, it's a highly urbanized place with a lot of migration in that area, and data management was very difficult because the population was very fluid, and we're not able to really manage the data very well. And you can see the gap difference. The gap, actually, all programs should work towards a gap of 0. And here you find in 2013, you can see the gaps. 488 minus 3,795, then up to 2016, 4,232. But from 2017, by virtue of the application of the QI model, we realize that the gap has been reduced significantly to 0 in 2017, 2018, 0, and then the next 1, 2 follow suit. So next slide. So this, what really has happened with regards to the various LF hotspots, where the gaps have been reduced to 0, comparing the combined treated population, non-eligible, refused, and absent, with the registered population. And if you look at it, it's just around 0. And that, for me, is a very, and that was done through data validation. And that is it. And that is one of the hallmarks of QI, where we sit down with the health workers and sometimes with the volunteers, and then we look at the data, we go for the registers and go through the data, and then through that, we're able to know what really happened on the ground. This is what we have done, and you can see that all the districts, the LF hotspot districts, have a gap of 0, and that is what the QI seeks to do. Okay. So let's go to the next slide. So lessons learned. We've done the improved sensitization. This is changed through an enhanced sensitization activities ensure that every household and groups were reached with MDA messages. Use laminated photos of LF mobilities in the campaign. Some LF softwares were also used to campaign as ambassadors of the program. And we use the new supervisory coverage tool also, yes. And the definition of resource and absenteeism were reviewed to fully accommodate 3 visits by CDDs. In other words, we engage the CDDs and made them to understand that if you miss a patient, a participant, a client, you really have to go back 3 times. And it seems to be helping. And that underpins why we have a gap of 0 now. Then we studied data validation and verification, where that is at the community establishment level, which help to prevent under or over registration of participants. It also helped to prevent under or over registration also clients that are taking participated in the MDA. Then we use the mitigation fluctuation population, where individual population separated from the migrants and other temporary settlements. So next, the way forward is to institutionalize the best practices in all the districts. So like I said, we are done with 15 LF hotspots. Now we have to, like I mentioned earlier, we have to evaluate the QI project next year, 2021. And then from there, we'll have to scale up to the rest of the country. So that is it. We want to institutionalize the best practices in all the districts. And I believe, I have no doubt in my mind that the next couple of years, we should be about breaking transmission in the remaining LF hotspots. Thank you very much.
Thank you, Dr. Mafo. So we have completed the 3 presentations now, one on the model itself, one from Sierra Leone on their planning of using the model and testing specific change IDs, and one from Ghana that has presented the result of their large-scale quality improvement effort applied to the performance of the NTD program. So we are starting now a debate with our panel of the three speakers. Go back to the previous slide. Thank you very much. And we've identified some key questions here regarding the application of this model to NTD programs. And I'm going to select the questions from the chat box. You can use the chat box to ask your question, make comments also. I'm going to select the questions that are most related to the ones that we have identified here, and ask our panel to answer this question. One of them comes from Dr. Samuel Okechukwu. So apology if I'm not pronouncing the name right. Asking specifically to Dr. Ugusan, can this quality improvement model work effectively and efficiently without considering the stakeholders and responsiveness to time? So Dr. Ugusan, do you want to address this question?
Yes, thank you very much for the question. I think you need one of the key prerequisite for the QI to work is that you need the buy-in of all your stakeholders, especially sorry, especially in health system where you have the big category of financing, a big category of leadership, including the community to which you provide the services. And of course, you need the buy-in of the administration at the peripheral level to allow you to work with them on the challenges and look for way to improve using those tools, those quick quality improvement tools. Now, there is so many quality improvement tools that we have taken from the industry, manufacture world, and adapted to health system. So those tools may need, I'll say, contests to which you could use it. So you need someone that is more or less knowledgeable of those tools, knowledgeable of in which situation will be appropriate to use this tool or the other, depending on your aim and depending on the issue you like to address. So we cannot address it without working with all the stakeholders, including that. But you know, those stakeholders have also, they are part of the input, and then you need to think of change of idea if they are not if there is no buying. There is always way for you within the QI framework to look for change of idea, to change their view, their perception onto your program and to your strategy. So as I said, you try one idea. If it works, fine. If it doesn't work, you change it and you try it again, and that should be applied to the specific stakeholder with regard to donors and other stakeholder in financial category.
Thank you, Dr. Augustin. And of course, the stakeholders include the beneficiaries, the clients who are benefiting from the NTD
Sure.
program, and they have to be part of the structure that Dr. Augustin presented at the beginning, which we call the quality improvement team. There is a question from on the methodology from Anouk Gouvras about whether all these changes are applied all together, and if so, how do we know which ones lead to improvement, which ones are less effective? And should we test the changes one at a time or all together? I think that's a question that could be addressed by Dr. Marfo, who has been implementing the changes using the collaborative model for improvement on a very large scale and testing a lot of changes at the same time. So, Dr. Marfo, what is your perspective on this important question that comes very often when we discuss the use of quality improvement? Should we test one change at a time, or should we test what we call a bundle of changes at the same time?
Thank you very much for the question. So we have to get back to our presentation as to what we did in Ghana. We started with a pilot district. That was not even part of the 15 LF districts. And based on that, we used that and we're able to upscale that to the 15 LF hotspots districts. Now that we have the data now, which shows that there's data improvement, and even the coverage has changed. So because in the past, sometimes you could get presumably a very good coverage, but data validation showed otherwise. But now the data validation shows that coverage is still high. So the examples I gave, like one of the districts called Tsunami Municipal, where we had, after QI, the coverage now stands around 84%. And that is real coverage on the ground. So based on that, the thinking is that you start small and end big. So the thinking is that if you want to begin, you may need to use our experience, go into one district, select one district, start working over there. That you may then do, from there, you may elicit the challenges that come up, the best practices also that come up, and then based on that, you're able to use that to move higher, and then you get better results, rather than do it all together at the same time, and that becomes very. Thank you.
Thank you, Dr. Marfo. Yeah, that's I would say a traditional question that the quality improvement team has to answer when they decide what changes to test and whether they want to test them all at the same time as a bundle or not. And the answer is very pragmatic. It's, do we have enough time, or do we know to test them one at a time, or do we know that there are so many factors, drivers, when you do the systems analysis of the issues, that it is logical to combine the changes to address all the steps, the processes, and the inputs that are the drivers of poor performance. So it's a very pragmatic answer in a way. And there's a lot of quality improvement effort that tests many changes in a bundle all at the same time, because we know that all of them influence the performance. There are several questions on incentive systems here for, I assume, for CDDs, maybe for the population too, I don't know. In terms of what are the incentives that work, monetary, non-monetary, what are the changes that have been considered based on systems analysis or have been tested already, like in Ghana, that have proven effective to motivate, I assume, the CDDs to improve their performance. I'm assuming that this is what we are talking about. So who wants to answer or address this issue of incentives and their nature and their sustainability?
Yeah, I want to address that one. Are you getting me?
Please go ahead, Dr. Ibrahim.
Yeah. In Sierra Leone, we didn't propose to the CDDs. They formed a committee, they met us, they said, because for the past 10 years, we have been giving them, or donors, through donors, we have been giving them t-shirts and bags, right? They came, they said they have sufficient t-shirts and bags for the next 2 years. So it will be good to convert that money and give them a monetary incentive this time, like they are doing at the polio campaigns. They called for it, right? We wrote back to the sponsors, said this is the case. And for the sponsors, it was even profitable for them because it is 5 days. 5 times 2 is $10. And those bags and t-shirts cost them more than $10. So for them, they said, okay, we are fine with that. So that is how we did it. And it's only per campaign. It's not something that is regular. You understand? Per campaign, right? It's $10 instead of giving them t-shirt, bags. They said they have more t-shirts. They have a lot of t-shirts and bags. So they can, at least they will appreciate it if we give them monetary incentives. So they called for it. We didn't force them. And the donors are fine with that idea. Yeah.
Thank you very much. Yeah, thank you very
Okay,
much. I think it might be an example also where the beneficiary population and the CDD themselves are involved, and you ask them, instead of deciding for them, what would you prefer in a way? you give the example of t-shirts and hats and everything, versus, well, give me some money that would help me, that would make it more feasible for me or more motivating for me to do this, because it's not a lot of money anyway per person. So again, the concept here, or the principle, involve everybody in the improvement effort and improvement team, the generation of ideas of changes, the testing of the changes. Everybody that is involved in the MDA, the NTD program, need to be part of the improvement effort and therefore of the improvement team at every step of the model that Dr. Augustin has described. Was there any additional reflection on this from Ghana, maybe? Dr.
Yes.
Marfo? Go ahead.
In Ghana here, what we have done is that we have engaged the communities, and then they have invariably come up with ways and means to motivate the volunteers. So in some places, some volunteers have been excluded from payment of local taxes, local tax. In that case, you know, in the communities, they do contributions in terms of local taxes, whereby money is collected from community members for the development of communities. And there is some of the volunteers are, in some of the communities, volunteers are excluded, and that is a motivation to them. And then volunteers have also requested that they need a form of identification in the form of ID cards. So in quite a number of places, we'll be able to offer ID cards to volunteers, which they use. Apparently, when they use these ID cards and they go to many places in the districts, like especially the hospitals, health facilities, they are recognized. I mean, with the moment they go with the ID cards, they are sometimes given, they are made not to join the queue, and then they are given some form of preferential treatment. Again, there was a survey that we did last year. It was an ECHO NTD survey, and then it came out to some of the findings. And so that's what we are using, where some of them also requested that we give them the special bags where they keep their where they keep the registers and other documents. And so this is also another motivating thing. And then also t-shirts. We have been able to supply La Costa t-shirts to many volunteers in the country. So these are some of the what they call things that we have done to, so to speak, motivate our volunteers in the
Thank you, Dr. Marfo. There are several questions regarding the application of the QI models to Schisto and STH also, and they are directed to Dr. Augustin. So I'm translating this as, would the QI model apply differently to different type of MDAs and to different type of NTD?
You can definitely apply this model to STH as well as other NTDs program. Due to the fact that there is a process for you to making sure that you addressing challenges that is recurrent, that need system thinking, because of course, if you don't change within the system, you will always have the same output. And to be able to apply to a program, you should be mindful to what you want to improve, making sure that you know you have a common. What is important is you have a common aim from all the stakeholders, and then you put in place a measurable monitoring system to allow you to collect the result of your change of idea, and then at least look through the data you've collected, and making sure that that data reflects what your specific objective you're looking for. So this quality improvement model can be applied in any to any public health program. Now, the most I'll say challenging issue with NTD is that is based on yearly campaign, But the model has been applied to immunization, which is a campaign as well. So I think looking at making that parallel to immunization campaign, we can apply to NTD and specifically to preventive chemotherapy NTD, including schisto and soil-transmitted helminthiasis.
Thank you, Kisito. Can you go back to the last slide with the 3 questions that we had identified for the debate, so we can address them in the remaining time, which is not a lot of time, of course, to debate on these complex issues here. But just would like to get from the panel, from someone in the panel, their perspective on how to integrate quality improvement into a program that operates through campaign, which is the issue that Kisito just raised here. The improvement model is used on a regular basis for the delivery of healthcare services, which is a continuous process. You know, patients come every day to a specific facility or service providers, and then QI is integrated in the day-to-day work. How to do this? How would you design the integration of QI and your test of changes in an NTD program? Who wants to address this very briefly so that we have time also to address the other 2 questions? Maybe Dr. Marfo, since you've done it in Ghana. Dr. Marfo, are you still with us?
Yes, I'm with you.
Okay.
Yes, I'm with you. Sorry about that.
Go ahead.
Yes. So basically, for the Ghana experience, we started by establishing the program fundamentals, trying to identify what the issues were by engaging the health staff and the volunteers. And I think this can be used not only in NTD, but in all other programs. I think that seems to be the basis for the QI, whereby you have to you try to know what is really happening on the ground. You engage the health staff, you engage the volunteers. They all come. You meet them and you have a meeting with them, and then they all come and tell you what is really happening on the ground. From all other angles, they will be able to open up to you. Then you are able to know where to pinpoint. The issues to do with volunteers, they will come up with it. The issue even to do with our own data, because by interacting with them, you begin to understand that there are serious issues with the data. So the basic thing is for us to really engage the health staff and our volunteers at the lowest level. So in Ghana, for instance, we have to go to at the sub-district level. We call the volunteers and the supervisors, that's the health workers, and we sat down with them, engaged them, and they were able to come up with some of the program fundamentals. And through that, we were able to generate the action plan. And that really helped it. And that was the first year. That's what we really did. Before we moved into the second year, where we did a lot of peer reviews at the various sub-district level, where we had to learn from each other and critique some of the change ideas that some of the teams had come up with. And that really helped. Then through that, we were able to really put together all the challenges and best practices that we had. And then we're able to use that in all the other 15 districts. Now, as I speak, based on the facts on the ground, we are just going to do an evaluation of the projects come next year, that's 2021, where we use the results to scale up to all the other endemic districts in the country.
Thank you, Dr. Marfo. Yeah, this is an example of a program in Ghana, from what I understand, a program in Ghana that has integrated an improvement dynamic within the NTD program and within the MDAs, where it's not just implementing the program and doing the MDA and then doing the survey after. It's improving each step of the process each time that an MDA is being done, from the planning to the evaluation. So, and for that, we need a methodology to do so. The model for improvement is one of them that is being tried now. And from what I know, this is new to NTD programs. It has not been applied to the NTD programs, because we look at the NTD program as a system, and every performance of every system can be improved through a model that has proven to be effective to improve performance of the system. And that's the model for improvement. By the way, FHI 360 is using this model, but did not design this model. The second question here is, how do we measure the effect of changes for NTD programs, which has to do with the design? How are you going to design your learning process, not only your improvement process, but your learning process, so that you can identify these best practices that Kisito was talking about, which is how we're going to make sure that we're going to have the right conclusion at the S phase of the PDSA, the study phase. How do we know that we are going to correctly conclude that a change that we tested has led to an improvement, it's a good practice, we need to keep it, or that it does not work, we don't need to keep it and institutionalize it in the next MDA and in the program. So what are your ideas on this? What is your experience on how you set up your test of changes? Anybody from the panel?
Yes, let me just chip in 1 or 2 points, and the others can join. So, for instance, in Ghana, we had to develop a monitoring tool, and I've alluded to that in my presentation, where we knew that we had issues to do with the data. So we had to generate the monitoring tool that had the population captured population. That's the population, the registered population, the population treated, the non-eligible, refused, the refused and absent, and then the gap. That's what we use, because with regards to MDAs, if you are doing good MDA, you shouldn't be able to pick any tangible gap. The gap should be 0 with regards to the summation of the population treated, non-eligible, refused, and absent. When you juxtapose that with the registered population, I mean, it should be around the same. And then if you want to elicit the gap, it should be around 0. So that is what the monitoring tool we had that we use to monitor, just to know what we've been doing. And we had to compare that to previous years. And then, like I showed you in the previous slides, then we were able to understand that definitely there have been major changes, because if you take a district like Shinani Municipal, in the past, when you added even the treated population plus the non-eligible plus refused and absent, the register, sometimes it went way beyond the registered population. Secondly, there was although we had the districts reported to us their coverage, but when the data is not accurate that way, then it becomes a challenge. So we're able to get this monitoring tool first, which we use to monitor, and that helps us to know whether we're on track or we are not on track, and that is what we did. And then so this is one way that we use, not only to be able to, so to speak, elicit the gap, but through that we're able to get the rare coverage in any given district, because now the data now is right. We're having instances whereby when you take only the non-compliance, sometimes the non-compliance percentage is around 30%. Then you find the treatment coverage around 85%. Of course, it's not possible. Then it goes even beyond 100%. So these were some of the issues that QI in Ghana we try to address. And it really, as you saw from the earlier presentation that I made, we're able to really bring some sanity into our data. And then as of 2017 to 2019, from 2017 to 2019, we'll be able to bring the gap practically to zero. And so that's a tool that we use, and that really helped.
Thank you, Dr. Mafo. I want to thank our panel, obviously, and the colleagues who have attended this session. We have to wrap up because we have reached the time limitation. The main message that I would like to share, that I'm also learned from this session, is that we are really trying something new here. So we don't know yet. We don't have the answers to all these questions. And so we need to keep trying, we need to keep reflecting, we need to keep sharing experience on this and the lessons learned. Remember that the model for improvement that comes from what we call the improvement science, it's a model for improvement and for learning. I mean, half of the success of an improvement effort is what we learn from it. And so it has to be designed correctly with the right model, the right tool, and the right approach. And so my suggestion is that we need to keep interacting on this and sharing experience, obviously. And I don't know to what extent it's possible to have a community of practice set up for managed by the NTD program, the FHI 360 NTD program, or the other NTD programs managed by other implementing partners and colleagues and the different countries, obviously. But find a common platform for each continuous exchange on this topic. There is a potential here for QI to really strengthen NTD programs, but we do not have enough evidence and experience yet of how to apply it best to achieve the result that we want to achieve. So that would be maybe a proposal or something for the programs to think about how to keep in touch. Many thanks to all of you who have contributed. Apologies that we could not address all the questions and the issue. We hardly scratched the surface of this of this very interesting and fascinating idea here. And so I want to wrap up by thanking the organizers, by thanking the donors and the sponsors who have made this session possible, the panel, the speakers, obviously, and I wish all of you a good end of the day, and stay safe. Bye-bye now.